in sustaining the Masters in Neuromuscular Orthodontics as an official Masters in Spain at the University Jae-bong in Plana de Castellón. I'm also a member of ICMO, and I hope you join ICMO and you join my mastership in Spain too. Okay, I'm quite aware that a lot of you have never heard of neuromuscular theory. So I'll try to make it as simple as possible. I'm quite sure that once you understand the basics, you will probably start having some interest. The problem is that the interest in neuromuscular theory has been very difficult in the last 20 years because actually you have to have a little bit of knowledge and have to have a new way of thinking that is very functional, by the way. It has a lot to do with physiology, but it takes some time to learn. So people are not always willing to go through the courses and try to learning new things. They prefer holding on to the old things, and and they keep going on like that. But maybe in the last 4 or 5 years, we have a little change in the trend. Okay, I've been working as an orthodontist from the late 1990s, and I started with neuromuscular orthodontics, and I try to make it a distinct branch from the beginning. I've had quite an experience also for TMJ problems, and I worked with a surgeon in plastic surgery and TMJ surgery in the hospital near me. It's quite a big hospital. So I'm talking to you from a very far away place. It's Albenga. This is north in Italy. You probably have heard of Monte Carlo, Cannes, Nice, Sanremo. I'm pretty close to Monte Carlo and Nice, and I'm about half hour away with driving distance. So what I'm going to talk to you today is essentially diagnostics. I'm going to show you a case or two at the end to give you an idea of how we apply the neuromuscular theory to treatment. But the most important thing is that we talk of diagnostics. I'm not going to talk to you about the brackets and how to apply certain pressure and how to do craniofacial orthopedics. I'm not going to talk to you about the essentials of orthodontics. I'm going to be talking to you about diagnostics. So let's talk just a little bit about the condylar position, okay? The most frequent pathological condylar position is probably posterior displacement. This has been seen in very many publications, and quite a lot of specialist doctors, a lot of time before myself, okay, agree that they've seen a posterior displacement in about 60 to 90% of all dental patients who have a temporal mandibular disorder. So probably the condylar position is important in the determination of TMD, probably, okay? So this is especially true for adults, but when we start looking at children, and a lot of doctors have been saying this for a long time, but orthodontists and dentists have not been looking at this. 25% of children with ages between 5 and 17 years have already TMD signs and symptoms. This is a fantastic publication. I suggest you take a look at it. There are many others, and most interesting is that headaches in adolescents are independently and highly associated with TMD. And their onset is before TMD pain, more specific TMJ pain also. So we have to have a starting point when studying the condylar position. I think that in general, it's the starting point that is the problem. Whenever we have a pathology, we start from that starting point, from that position of the condyle, and from there trying to find a working position. I think intrinsically, this is the basic error. The basic error is wanting to try to start from a wrong condylar position, or anyway, a condylar position that will not make my disc work properly. So we've had a series of studies on the condylar position, and we know that in the adult, probably the condyle is altered in its anatomy, and probably the anatomy in an adult can probably correct itself once we change the condylar position in what you can call a correct functional position. And we also know that if there's a growing condyle, like in a child or a young adult, the stretch action of the tissues we apply to the condyle actually change the shape of the condyle. Remember, there's also a center of growth in a condyle. So in children, the condyle and the entire mandible are growing. So this intrinsic repair is present, and it also includes the fossa. Here are a couple publications. This is a systematic review. I exhort you to go and check. It is concluded, though, that even if we have the probability of changing the morphology and anatomy of the glenoid fossa, still, it really depends on how long this pathology in the TMJ has been going on. So that is why I exhort you to look at children better for TMJ signs and symptoms from the beginning. And that's where orthodontics is, because in a child, you will be performing orthodontics. So what I really want you to focus on, besides looking at these publications, is that the fact that you as an orthodontist are going to be practicing a type of orthodontics that must respect future growth of the TMJ, okay? So the object of the neuromuscular treatment is to identify a mandibular rest position that will not strain all the tissues, and most of all will probably be the most functional position so the disc works properly. Now, there are a lot of studies about the condylar position in the class 2, and they all fail in one way or another, because some studies will use a scan, an MRI scan. Some studies will use a CBCT. Some will divide the space according to old classifications. Some will say we'll take analysis the anterior and the posterior joint space. But what we're really interested at the end of the story is how the disc works, if we're really interested in having a functional occlusion. Why? Because the majority of the literature focuses on the fact that there should be no noise of the TMJ when it works properly with the disc. So now we got to go look at the malocclusions we're usually classifying as a class 2 division 1 malocclusion, for example. And the big surprise is that most of all, we have that the majority of the publications say that the condyle is in a more forward position, okay? And that's not always true, but in the majority, that's what you have, especially when you have an increased overjet, according to these publications. Do we trust these publications? Probably. They don't always all say the same thing, though. So if I have to talk about the class 2 occlusion, I'd say that when we use a device TENS, and I'll be talking about that, to relax the muscles, generally speaking, in class 2 division 1, the mandible comes down and forward. Like if the condyle with it was distalized, was up and back. And this doesn't necessarily have to be true, because we've seen that the condyle position can be in a more forward position in class 2 division 1. But actually what happens is that, yes, it comes down also and forward, like if it were expressing the direction of growth of the condyle in growing patients. And most of these studies anyway lack to discuss what would be a concentric, what would be the correct position of the condyle. So since the disc is the most important thing, we know that if the disc is working correctly, there will be no signs and symptoms of TMD dysfunction. At least that's what the literature says. And if we have to talk on class 2 occlusion, as a neuromuscular orthodontist, but mostly as a functional orthodontist, we'll try to divide the class 2 occlusion and the class 2 skeletal individual in a positional class 2, where, you know, the condyle is forward or concentric, the mandible is normal in size, and it probably comes down and forward when I use any system to relax or to distract the muscles from the occlusion. And I'll say it's a skeletal class 2 when the condyle is not in a retruded position, but I do have a skeletal class 2 mandible, which is smaller than normal for sex and age, okay? So when we measure the cranial base, for example, and we measure the length of the mandible, we have norms that tell us that a skeletal class 2 is going to have a smaller than normal mandible. This kind of malocclusion, which fortunately, which we're really lucky, is going to be only in a small percentage of cases. I'd say between 5 and 7% of all class 2 division 1 malocclusions. So how do we treat these? We will not have any mandibular growth. These patients will always have a mandible that is shorter than normal for age and sex. And we can't make this mandible normal. We can't make the ramus grow. They're going to be slightly open bites. These patients usually, as they develop, are surgical patients. And the only way we can treat these patients is by a compensation of the vertical growth of the upper maxilla. So you'll probably be using any vertical force applied to the upper maxilla. This will make the mandible close forward and enter and reduce overjet. What we are interested in is this, which are the majority, about 95% of our cases. And here I want to introduce to you the concept of the neuromuscular theory, okay? And I want you to focus on these 3 elements of the stomatognatic system: TMJ, teeth, and musculature, okay? And take a look at the central nervous system. And please note that the teeth will always send signals to the central nervous system, okay? These afferent signals will always give you an idea of where your occlusion is and where your mandible is positioned. Imagine it, this system is so refined, is so perfect that actually you can focus on biting a hair between teeth, okay? Also, the TMJ is sending afferent inputs to the central nervous system. And the central nervous system has to coordinate the position of the mandible, okay? And how does it do this? Well, also musculature is sending afferent inputs to the central nervous system. And the only way the central nervous system can act on the stomatognathic system is through the activation of the musculature that has to do with the stomatognathic system. Now imagine having these three individual, Mr. Musculature, Mr. TMJ, and Mr. Teeth sitting on a table, and you have to do something to have these three work together, okay? Work together and create an harmonic relationship. So we know that the dentist can work on teeth, and when moving teeth will always affect the TMJ. Why? Because teeth are linked to the mandible. When I change the mandibular position, I am changing the relationship of the TMJ components. So we have been always focused on teeth and how changing the position of teeth can take effect on the TMJ. Okay. And we've always been, kind of focused on the fact that the musculature would adapt to the position of the teeth. Okay. And what the occlusion we were creating. I remember in the 80s and the beginning of the 90s, when we were doing straight wire, we wanted to create a centric occlusion, an ICP, a centric occlusion in which everything was very locked, because we thought that would reduce relapse. So we were looking at the Kia 5, we were looking at the torques of the laterals. We wanted to lock occlusion in ICP because we thought that was the most important way to stabilize occlusion, okay? Well, it turns out, and many doctors know this, that it's the other way around, that working exactly the other way around gives you the best results of stability and function. So we've been focused a lot on teeth, and I'd like you to start focusing on muscular. Why? Because if we have to have these three working together in harmony, we have to have them talk between themselves. And I know I can change the position of the teeth and affect the TMJ, but I will never change the anatomy of musculature. Its origin, its insertions cannot be changed by the dentist. So if we want these three to go together, we have to give a clear response to the necessities of the muscle. Only this way we can have all three of these elements work together, okay? If we start listening to the muscles and then adapt to occlusion, we probably will have all three working harmoniously together. So what happens is that when you have a malocclusion, and everybody in a way or another is maloccluded, the muscles will accommodate. This accommodation is a reaction that is triggered when the body is forced to work under less than perfect condition. This works, if you're walking and you have one leg longer than the other, and that is probably the case of everybody, your muscles will accommodate to work, okay, in equilibrium, even though there's an anatomical asymmetry, okay? That's what muscles do. This is called accommodation. And accommodation creates a specific muscle avoidance pattern when the pattern is compromised as the mandible enters centric occlusion. So if you have a premature anterior contact, the occlusal disarmony this creates will create an avoidance pattern in the muscles, and you'll try to avoid that as you go in centric occlusion. This is called engram, okay? You can go and see this publication and study, oh, excuse me for that, and study the engram. This is very interesting. You can go in Cranio, and this is Dr. Lerman. This is 2011. This is very interesting. You can do an experiment and check the engram by yourself, okay? So I'm going to try to make a long story short. All we do is measure this in neuromuscular orthodontics. And I just want you to imagine that we are looking at I don't know if you can see me, but laterally, okay? And this would be centric occlusion. This is when you open and close in centric occlusion, okay? And then we relax you, and then you probably, as you relax, you come down and forward, okay? You probably have a rest position up here, usually have a rest position up here. And now, after relaxing you, you have it down here. So this will be your upper incisor. This would be centric occlusion. And this is on the frontal, okay? And this is what the tense spike is doing here, okay? We've relaxed muscles. We've put something between your teeth. So although those afferent signals we've been sending to the central nervous system are interrupted, okay? That's what you try to do when you put a bite, okay? And then we stimulate with the tens, and what happens is we create.
This is scan 4-5 obtained by mandibular tract.
Okay, this is, sorry, that's the oral explanation. But this is the neuromuscular trajectory, okay? And this is a whole new trajectory. This is very physiological, okay? It has nothing to do with teeth, okay? So if we create a position, we record a position on this neuromuscular trajectory, the occlusion, and we create an occlusion so that we respect the neuromuscular trajectory, we have a neuromuscular occlusion. It's all there. It's all very easy. It's a little bit more difficult to perform. So the treatment objectives of the neuromuscular orthodontics are that the occlusion is the result of the balance functions of the muscles. We will never pretend the muscles have to be balanced from our occlusion. That will never be the case, okay? And we go in centric occlusion when we swallow. Remember, we don't go in centric occlusion when we're just chewing, okay? The habitual rest position of the mandible is the result of relaxed postural muscles. There is no change in muscle tension, okay? Just to give you an idea of what we do is we have a malocclusion, the muscles adapt, this gives us stress, we relax the muscles, how? With a TENS device, we find a new rest position, we do a bite recording, and what we do is we create a new craniomandibular relationship. We adapt dental occlusion to this relationship, and this is our orthodontic therapy. So we're working the other way around. This is a TENS device, okay? I'm not going to talk to you about the 250 and more publications on ultra-low frequency TENS used in dentistry. But actually, the effects are very many. We get muscle relaxation. We can use it for occlusal diagnostics, occlusal registration, treatment of TMD, treatment of pain, pain treatment, okay? And we know it works on these muscles, okay? And I won't stop on this very much, but remember, it pumps waste and lactic acid from the muscles, increases blood flow. It changes the metabolism of the muscles. And this or the endorphin effect. And all these effects are usually done within the 40 minutes application. You think it's difficult? It's not. I do it to children. We have fun. We talk, together when we do this, and then we do a bite recording, and we get a bite recording. And in the more complicated cases where I need to do not only TENS and a bite recording, I can do a complete diagnostic setup with mandibular tracking, okay? And I do it on children too. This is the kid, and we're working on him. And we do electromyography, mandibular tracking. And what do we put in between the teeth so that we can interrupt all the afferent signals that go to the central nervous system? I use an aqualizer, okay? And there are different size aqualizer, and of course, they have to respect what freeway space the individual has. So let's see what happens in a class 2 division 2 occlusion in which I relax with TENS, okay? So take a look at the relationship between the molars, okay? And this is a normal rest position of the individual. So here he is, I tell him to relax, and this is normal rest position. But what I do is I can apply a TENS for 45 minutes, and this is a new rest position I have, okay? And is there a difference between here? There's a big difference, okay? Now imagine that usually you close, the path of closure is about 45 to 60 degrees, okay? This path of closure brings you back to the starting position we have here. But in this case, the path of closure here would bring me to a class 1 occlusion. That cannot be for the problem we are having on the premature contact of the lower incisors. Do teeth adapt to occlusion? Yes, they do. Look at the lower incisors here, how they have adapted in time, okay? Because the mandible is trying to go forward and the incisors have just adapted. That is something we can only see. This craniomandibular relationship can only be brought to you when I deprogram the muscles, okay? So that's after 45 minutes of TENS. So now I want you to think 3D for a second, okay? So what does that mean? What it means that everything you do to your teeth will, change the position of the condyle and the mandible, okay? And what Jankelson used to say, if it has been measured, it's a fact. If it's not measured, it's an opinion. So we do a lot of computerized jaw tracking. Actually, we measure a lot. And these measurements are very accurate. This is 1 millimeter from here to here. So we're able to measure up to 1/10 of a millimeter. I'm not going to annoy you about computer jaw tracking today. I'm going to talk to you about the fun things. So if it's true that the mandibles are trapped from the occlusion, if I untrap, if I give mandibular freedom, in certain cases, the mandible should come forward by itself. That would be proof that the neuromuscular theory actually is true, works. So I'm going to show you, I'm going to talk to you about what mandibular freedom and spontaneous mandibular migration is. So let's see this. I've talked about the class 2 occlusion. Usually they're positional, and the mandible will come down and forward after TENS. The class 1 occlusion, where mandibular entrapment with the condylar is posteriorly displaced, the mandible will come down and forward after TENS. And that's even in a class 1 occlusion. That means it would probably be a class 3 functionally. And then you can have a class 3 in which you do not have a reverse overjet, in which you see a class 1 dental occlusion. And that also is like a class 1 occlusion I just talked. It'll come down and forward. Then we have a class 2 skeletals in which the mandible does not improve after TENS. And open bites lack a freeway space, so they're not candidates for the use of TENS. So we'll take those away because that is not part of the diagnostics we're going to do with TENS. So if we prepare occlusion for a spontaneous correction of the occlusal class, we will see what I call a spontaneous mandibular migration. The mandibular freedom has to come first, and then we'll see this migration of the mandible, okay? I've talked about this in one of my publications. So take a look at this case. It's very simple. We have a class 2-ish, okay? In this case here, deep bite, okay? And what am I doing here? I'm just aligning. This wire is very, very, very soft. I mean, it's very, very soft. And I'm not going to do anything on the lower arch. And I just put on this wire and wait. This is August 2002, October 2002, November 2002. I'm unlocking the lower arch. As I do this, the mandible, look at this, comes forward. It just follows. It follows my upper incisors. We were 2-ish here. Now it's 3-ish here. We have the 5 that is in contact with the 6. Upper 5 is in contact with lower 6. This is a class 3 now, okay? Class 3 in March 2003. What I do is I measure freeway space, and I have a lot of freeway space. Record that freeway space, and then, this is to show you, that is the only way I can align the lower arch is that if I extrude. So when I extrude, I reduce the anterior-posterior relationship. You got this? When I extrude, I reduce the sagittal relationship, the anterior-posterior relationship. To make a long story short, I'm not going to explain this 100%. This would be the final occlusion after I've extruded and I have corrected the craniomandibular relationship according to muscular position. Let me give you an example case. I'm sure you'll like this. And I'm also sure that it'll look easy because it is easy. I'm not doing any mandibular tracking here. Look at this girl. We're in March 2018, okay? What we have here is we have a patient that really wants to change. So I need collaboration, okay? And if we take a look at this X-ray, this is going to be a positional class 2. The mandible is normal in size for age, sex, cranial base, okay? And this is the panoramic X-ray, and all her teeth are there. And she's changed all her teeth. Her 7s are about to come down. So she's almost an adult, but she is still growing, okay? So this is how the situation is in March. We have a box bite here also, okay? This is a nice overjet, a class 2 occlusion, okay? Nice class 2 occlusion. You can see that in the canines, at the mandible. There we go. There we go. So, what do? I have to accommodate. So, let's see my rapid palatal expansion. Don't get scared. It looks like a complete box bite. It is probably. I like to expand very much class 2, division 1 and division 2. And here I've expanded accordingly. And if you're surprised of the quantity of the expansion, sometimes I do this even more. And I keep that expander there, and I start working on my lower arch. See my lower arch? Great. what I do is I do a mandibular recording. Okay. And I'm going to show you that after this recording, I built a bionator, a modified bionator. And I start extrusion. I start correcting where the malocclusion is. That means the lack of posture support. Class 2, Division 1 is essentially a vertical problem. It's not an anterior posterior problem. When you talk of anything that sounds like sagittal first, I get a little sick of that, because that means you've not understood what a Class 2 Division 1 is. Class 2 Division 1 and Class 2 Division 2 are not sagittal problems, are vertical problems. And I'm going to show you how I extrude and how I correct this problem. Now we're in October 2018, and September I do the recording. I put in the device in October 2018. That's October 2018. I give the elastics. In November, I have a Class 1 relationship. How much time did that take? A little over a month. A little over a month for 6-7 millimeter overjet. A Class 1 correction immediate. Look at the freeway space between the 6s, because the first thing we do extrude is the 4 and 5. Look at that's a Class 1 occlusion there. And I know I can even gain more, but I'm starting to have contact with the upper incisors, which are rotated. So I know I have to work on these. So here we go. I start to work on the upper incisors. Look, I'm working only on the upper incisors. That's cut over here and there, cut over there. The 0.14, I'm just going to, line them up just a little, okay? And this in February 2019, okay? I'm still working I still don't have full contact of the molars, okay? But my premolars are pretty much guide, okay? And now I have a full wire. I've engaged the full wire, okay? This is the correction of the profile I'm having. How am I having this? Well, I'm having this because of the mandibular advancement and because of the change in the cranio-cervical posture. Okay, I talked this about this in my publication here. You can go and check. What happens is that when you use up freeway space and extrude, you have head extension. So when you take pictures according to natural head posture, which is something very precise to take pictures, this is the change you get. You want to know aesthetically how much the mandible has come forward. You do a superimposition and you can see it. You can see the soft tissues here, how much they advance. And that's quite a lot. Okay, but it's not something I advanced. It's the request of the patient. So look at frontally how she's changed. March and February. Isn't this beautiful? Look at the profile, the front profile, how the lips have changed, and she's looking much better. Okay, and I'm going to show you the video. I hope you can hear the audio. Here it goes. Okay, this is our case, Class 2. Deep bite, excess freeway space. Look at that overjet, it's real big, okay? Still some silicone in here. What I did is I recorded a new position after tensing. And this is the position we got. Let's check it out together. Cody. And that's the new position. And if you look at it this side, it's almost a Class 1 occlusion. Look at the overjet now. It's really reduced here. Okay, let me take that out so you can see it again. Open, close, That's the big difference. Open. Close. So we just made a bionator here. And this is how we're going to insert the bionator. And this is done on a neuromuscular position. Up here. Up here. Up here. Good. There it is. What we're going to do, we're just going to just reduce this right here in front. We're going to take this, all this piece of the bionator away. We're not interested in that. And she's going to decide if she wants to keep the lateral part here of the bionator, or if you want to take that away too. And then we're going to start extruding our teeth. And we're going to need some extra space for the incisors. Thank you. Okay, so if you take a close look, look, it's a nice box spine. Isn't that beautiful? That's an expansion. That's what I call expansion. Okay? Now, here's a modified bionator. You can see we carved what we want to obtain with this bionator. And open up. There you go, baby. Close. There we go. This is what we're looking at. Take a look here. We're going to start extruding here. This is going to work more like a stop here, the lower 5, and extruding up here. Elastics, we're just going to start with something very light so she can get used to it. There's 1/4, 6.5 ounce going on both sides. And that's just it to start. And this is after 2 months. And she's, these are the elastics she's wearing, they are box elastics. And now we're going to check how her occlusion is. And this is a bionator. And this is, you can see there, this is what we've been doing. And now we can go and check what is the difference with the previous occlusion. So now you can see there's a big result here. First of all, looking straight in front of her, you can start to see the brackets. And let's take a look at the overjet. It's almost done. And she is about to slide in a class 1 relationship. She has a lot of growth still in the posterior, but the premolar is already working fine for us. That's what we're looking for. Molars will come later on. And let's take a look at the profile. It's much better. Okay. Okay. So, May 2019, and you see we're starting to get a molar contact here. We have some little bit spacing here. It's good, no problem. And so this is how we started. This is when we are extruding here, have the contact here, and this is how we're working on it. And this is January 15th, 2020. We were going in lockdown, so we had to slow down then a little bit. And you can see here I have a little bit of buildups on 7. I want to keep them away. If I'm not banning them, just keep them away. I don't want any interferences on the 7. And then I'll take this away later on. They'll go into occlusion by themselves. And here we go. We're finishing the case here with lateral elastics. That's all I'm using. And this is the finished case. This was this month. And she has no retention. And, you know, it's not fun. Believe me, I'm just trying to prove myself she doesn't need retention. And what am I doing? I'm checking her every month. And we're looking at those teeth carefully. And I just want you to think 3D now. And I just want to go and conclude to the final procedures that might be of interest to you. And orthodontic procedures that are not neuromuscular, that are not physiological. Okay? Correction of lower negative torque without adequate freeway space. If you correct the lower negative torque of the incisors, you'll be distalizing the mandible. I'll show you that in a second. I probably distalized 2 times this year on my patients. I never distalize. Face grows forward, mandible has to come forward. I do not distalize in my office. Only in skeletal class 2, a slight distalization if needed. If you don't extrude with an open bite, why should you intrude in a deep bite? Okay, when there's excess freeway space, why would you intrude? I never intrude in a deep bite. I extrude in a deep bite. Okay, I never flatten the curve of spee. You should never flatten completely the curve of spee. That's not physiological. I try to reduce the overbite. What is considered normal in orthodontics, a normal overbite? When I learned that in the 80s and 90s, it would look to me today as a deep bite and with excess overbite. That's what it would look to me today. I work the other way around. I have very little overbite. The incisors, uppers and lowers, should never touch, okay? And the low torque of the upper incisors is something that is absolutely wrong. We should always use open torque upper incisors, except for very, very open bite cases in which there is a compensation. But even that is something we should discuss, okay? Now, take a look at this. If I have a case like this, you see in white here, and I want to correct my lower incisors, I see this every day of TMD patients come in my office that have done orthodontics. Correcting the lower incisors here will just distalize the condyle here. So if the lower incisors are in this position, it's because there's been a compensation. The compensation here is actually giving space in the condyle here. If you try to correct that, you'll distalize the mandible. You'll create a TMD patient, okay? What are the orthodontic procedures that you should do that are supposed to give you a physiological response, okay? Okay, first of all, you should always reduce the lower protrusion. Whenever you have protrusion of the lower incisors, if you can, you should reduce that. Now we see with buccal shelf and other orthodontic implants, we can distalize the lower arch. Whenever you distalize the lower arch, you are giving space in the TMJ. You are forwarding the condyle a bit. You should always lower arch distalize when needed. Extrusion when there's an excess freeway space is the answer I told you before. When you have a lot of freeway space in deep bite, you should extrude. Whenever you extrude, you reduce the anterior-posterior relationship. Correction does not mean flattening the curve of spee. When you have an excess curve of spee, you should never look to flatten it, to reduce it, and to make it a correct curve of spee. You want to know how much that curve of spee is supposed to do? Study the monsoon theory. It's very simple. Reducing the overbite? Yes. We have to reduce overbite. Excess overbite leads to mandibular entrapment. And the transference discrepancy is solved only with determination. That means if you want to expand, you have to really expand the bone, not the teeth. That means rapid palatal expansion. So let's take a look at this. I have an anterior wall. I extrude posteriorly. I can correct the upper incisors, but most of all, I can advance the mandible. So whenever I correct vertically, I have an anterior posterior correction. Whatever, the best orthodontist is always the one that controls the vertical dimension, that controls freeway space. We in neuromuscular dentistry control freeway space. What is neuromuscular orthodontics? What is neuromuscular dentistry? It's finding the physiological rest position. That has nothing to do with occlusion. So, always the big dilemma, form function. We should always look and study swallow and parafunctions. And we should look at the form as skeletal type, the anatomy of the tongue, teeth, and occlusion in ICP. We should never interfere with deglutition. So we're trying to use orthodontic appliances that will give freedom to the tongue. Reduce minimum necessary any interruption of the periodontal afferent inputs to the central nervous system. Yes, we do that for diagnostics, but we will not cover the teeth for a long period of time, so we interfere with the afferent inputs to the central nervous system. Why? Because we need contact between the teeth, because that is the only way to stimulate the central nervous system. That is the only way we can have neuroplasticity in a normal fashion, okay? We must reposture the mandible. Sometimes we have to do this gradually. Lip competence is important during and at the end of treatment. And compliance therapy is always our first choice. Always achieve mandibular freedom in all orthodontic cases. I hope this has been clear, and I hope that you have questions, because I love answering